So I'm thrilled today to have a guest that I think everyone's going to really enjoy. And before I go into a little bit of Dr. Pearl's background, I just on a personal level, I'm talking when I was in medical school and residency, I would admire Dr. Pearl from afar. Uh, so it was the first time. This was years ago. I heard Dr. Pearl in interviews, done many interviews on TV. There isn't a network. He hasn't been invited to speak on. So I don't know which network or which interview it was, where it was the first time I heard someone say it's not a healthcare system, it's a sick care system. And this is like over a decade ago. And that's when I started to watch, and then two of my favorite books were written by Dr. Pearl. Um, Uncaring and Mistreated. Excellent books for anybody in the healthcare space or curious, an insider's view on what maligns the healthcare system. And I like those two books in particular because one covers a little bit of what goes wrong as a doctor, right? You go into medicine as a doctor wanting to care for people, wanting to help people. And on the output side, all of a sudden, we're the ones delivering care and this care is not working. Kind of what went wrong from the education process to the mental state of the doctor. It's a unique, it's a tough question to grapple with. It's the right question. And then the other one talks about what patients misunderstand and why they're not getting what they think they should out of the healthcare system. So it's kind of both ends of the funnel. And so two excellent books. I have them upstairs in my den. They're great. But to be honest, and I don't think this is an overstatement by any stretch, um, when I look at the past 2 to 3 decades, of healthcare, I don't know of a physician leader that's more accomplished in the country than Dr. Robert Pearl. And, I don't know you, Dr. Pearl, but I watched you and you have a reputation, one of humility, and so, I don't wanna embarrass you with this, but I mean that very objectively. And I've worked, I've managed thousands of doctors when I was at Optum. I been in leadership positions, different boards and healthcare hospitals, whatever. So I've been among some of the most esteemed physicians and healthcare leaders. But I don't know of anybody. You obviously, Dr. Pearl ran the Permanente Medical Group. It's one of the most respected, not only largest. Every time that comes up, they talk about how large it is and thousands of doctors. That's one thing, but also led the charge in value-based care before it was a thing, really. And that's what I find so admirable. And oh, by the way, on the side is a professor at both Stanford Medical School and Stanford Business School. And writes is a prolific writer on all things healthcare. And so when you look at the career that Dr. Pearl's put together, I think in terms of an authority, an insider in healthcare, and a physician, there's nobody whose perspective I find more compelling or interesting. And so I'm very, very pleased that you're able to take the time. I know you're in California on the West Coast. That's why we're doing this virtually, and it's kind of you to carve that time out. And what I would like, Dr. Pearl, is, I've blabbered enough about you at this point, but I think it's I'd be curious if you could talk a little bit about your journey. I know, you could start from whether it was Yale Medical School or when you did your residency at Stanford, wherever you want to start in your journey that led you on this illustrious path.
Your words are too kind, and no one should really believe them all, but it's nice to hear them. My parents would be pleased were they still alive today. I think my journey really begins in college. I went to college, I was 17 years old. I wanted to be a college professor. And the person who I thought was the most brilliant teacher there didn't get tenure. Not because he didn't publish great work, he went on to become the chairman of Reed College, but because of his politics. And I decided as a naive 17-year-old that I wanted to go into something that would be non-political. Because how could you politicize life and death? I decided that that was going to be medicine. So that's how I decided to become a physician. As you said, I went to Yale Medical School. And then I came out to Stanford to be a heart surgeon, actually. But after 2 years, I went on a trip to Mexico with the chairman of plastic surgery. and I had a chance to fix children with cleft lip and cleft palate. And I decided that that was truly my calling. This opportunity to change the human life in an hour and a half of time. That was just so amazing. Every time I could see the tears coming down the mom's eyes because her child that she knew was doomed now had a chance in life to be successful, to have a family, to get married, to have the kind of fulfillment that we have. And to me, that to me is the fundamental value. I did my residency, and then about 6 months before the end, I was planning on going to South America and fix children with cleft lip and cleft palate again. And the plastic surgeon at the Kaiser Hospital of Santa Clara died in a very tragic plane crash. They called me and they said, Robbie, would you come and fill in just till we can find someone else? And I said, what can I lose? And I went there. I never actually been at a Kaiser facility prior to that time. And I felt like I was at home. I was in a supportive community. These weren't doctors competing, these were doctors collaborating and cooperating. I never had it to ask anyone, could I do something? I was empowered to do the right thing for the patient. I knew I'd have quality reviews, of course, and patient satisfaction would be very important, but not a question of cost. I never once had to think about cost. Just do the right thing, keep the patient healthy, get the surgery right the first time. And out of that, my experience grew. I was asked to take on a variety of leadership roles. I became the head of that facility when I was becoming the CEO in Kaiser Permanente. It wasn't a job actually that I wanted. It was 1998. The organization was down to 2 days of cash. We had to borrow a third day to stay in business. The CEO got fired, and they asked me whether I would consider taking on the job. The board asked me. I asked a couple of friends, I said, you guys, you're really skilled. Why don't you do it? They said, "Are you out of your mind? Leading an organization is this close to being out of existence?" So I stepped forward. And as I describe it, it's my second career. My first career is as a surgeon. My second career became as the CEO. And then I did that. And at the end of several years, 18 years, I felt like I had done what I could do. Kaiser was number one out of 1,000 programs in the nation in quality, according to the NCQA. We'd had 70% of routine visits, same day, next day. We offered cost to employers that was 10% lower than the competition, and the physician satisfaction was 20% higher. And so I embarked on my third career, which I am now. As you say, I've actually written my third book called ChatGPT MD, How AI Empowered Patients and Doctors Can Take Back Control of American Medicine. And by the way, all of my books, the profits go to Doctors Without Borders. And as you say, I'm trying to come on shows like yours, podcasts with large audiences to help people to understand what can happen. Based on what I read, it takes about 30% of people to make transformation happen. And I believe that transformation will be essential if we're going to make American medicine the best again in the world once again.
That's incredible. That's inspiring. Um, I want to pick and choose. There's such a large swath, Dr. Pearl, with your expertise, your experience, what you've done. The hard part in a conversation like this is what to pick and choose to talk about, right? There's just so much I can go over with you. And frankly, I feel like I'm just picking a mentor and expert's brain for myself and just the benefit of people watching the conversation, as opposed to some of the conversations. This is less educational for the audience and more for me. And I hope they benefit from it too, just to be honest. My dad was a physician. He was a physician leader back when, on a much smaller scale, but for the world we were in, he was very innovative. He was disruptive in the primary care space, and so this is kind of in my blood, and it's actually the foundation of what we're building out here at Baker Health. And so I'm just excited by those words and inspired. I want to start. I do want to get into your most recent book, and I want to get into some of the more modern quagmires that define healthcare and get your take on them. But before we leave your personal journey, a lot of the folks that listen to us and tune in are in healthcare. Um, what what are the some traits or one trait that you feel has made you the leader that you have been? What there's some what I call common denominator traits, right? I'm one of those guys. I'm old. I'm younger than you, but I'm very old school. You're not going to convince me that you could be the leader and be accomplished and not work your butt off. That's a common denominator trait to me. First in, last out. You got to lead by example. You need to know your stuff, right? You need to be really good at what you do if you want to tell other people what to do. And so those common denominators. What are some of the hard to see, less obvious traits that have propelled you to these heights of leadership in healthcare?
The first praise that I would give is to my parents. They helped me to understand strategy. That's what I teach at the Stanford Business School, but I actually learned it from my parents. How do you look at a situation, one with a certain degree of ambiguity? And in looking at that situation, figure out where the highest probability of success is. And it's never 100%. And how do you make that commitment? And how do you have the courage to step forward, knowing you might fail, but knowing that unless you step forward, change won't happen? So that's, I would say, a personality that my parents instilled within me. I think the second thing that they taught me is that no one really cares how much you know until you know how much you care. You have to understand and empathize with people. If you can't see the world through their eyes, they're going to know it and they're not going to be willing to follow you. You have to be willing to surround yourself with people who are smarter than you are, smart in a variety of areas, and then you're able to leverage off of their expertise to make the right choices. And I got very lucky that I had such people in my life, both when I was in Santa Clara and then when I became the CEO, people who I could trust to make the right decisions. And I'd say finally, you need to know your values, because what happens in leadership is that you have to make difficult choices. Almost no one else in an organization has to do that. And ultimately, it becomes a decision by the leader at the top. And how do you make that choice in a time of uncertainty? And I think if you have values, you can make that decision. And once people understand those values, that strategy, then they can make the decisions without you having to tell them what to do. Our strategy is very simple. We're going to provide quality and service differentiation at a competitive price, not 14 pages of strategic vision. No, a very clear area. We were going to lower costs by raising quality. We were going to save money by keeping patients healthy, by avoiding medical error, by doing the right thing the first time and not having to redo it. Those are pretty simple tenets. And when you start knowing those things, people will make the right choice. And again, I was very fortunate that I had the privilege of leading over 12,000 very dedicated clinicians.
That's that's great. I want to maybe segue into the next topic from that last comment about strategy and keeping the mission very, very simple. Um, I've I couldn't agree more. Some of my team actually gets frustrated because I will just in the middle of kind of an explanation of something in a leadership meeting, I'll say 60 seconds or less. 60 seconds or less. And if you can't get it out in 60 seconds or less, it doesn't mean you're really smart or that the idea is complicated. It means you don't know what you're talking about. Right. And so that simplicity, that clarity is necessary not only for soldiers or your doctors or whoever to be able to follow something, right? It's got to be clear. If you can't see it, you can't follow it. But actually, it's a good personal exercise, I find. It forces the individual to get clear on things, to cut out the fringe stuff, the distractions. And so I'm with you 100% on that kind of thought exercise. I want to pick up Dr. Pearl, if I may, when you talk about the tenets and the values that, de- delivering high quality care at low cost, and some of the other values. Anybody who listens to this says, of course, that's what healthcare is. Of course, that's why you become a doctor. Of course, of course. And yet, one of the reasons you are who you are is you did the impossible. You actually executed. And the country is full of the other 99% that is very fee for service, very high cost, very low quality, where outcomes have actually in many ways gone in reverse, where antibiotic resistance is up, not down, where mortality rates for many people, depending on what your zip code is, are higher than they were 10, 15 years ago. And these are shocking statistics, but life expectancy has gone down, not up in certain years. I mean, the obesity rates, diabetes rates, all the stuff that we didn't have, we've actually introduced more disease than we've gotten rid of in many ways. So somebody might say, well, what you guys are saying makes sense. I buy it. But look at all this that's happening. And my question to you is, the values you just articulated are not unique to you or me. What's unique about you is your ability to execute on them. Where is that dissonance with everybody else? Why is it that even though many people share those values, they agree, they'll nod their head? And by people, I mean CEOs of hospital systems, CEOs of health insurances, people who can, move the needle. There's, I don't want to say universal failure, but pretty darn close. What is it that's wrong in the system? And I know that's a very complicated question, and you could take it however you want. You want to talk about, private investments, you want to talk about big pharma, but I'd just love to hear your answer to that.
One of the things I emphasize in the class I teach in the Stanford Business School, I also teach in the medical school, but in the business school, is that strategic thinking without action is powerless, and action without strategic thinking is aimless. So you need to have this direction, and you've described it nicely, and then ask yourself, how do I translate that into action? Now, I think one of the big challenges in American medicine is the fee for service. I call it the pay for volume that incentivizes you to simply do more. What did Charlie Munger um, say? So tell me your incentives and I'll tell you the outcomes you're going to get. In a pay for volume system, you're going to get a lot of volume. But I think we often say pay for value, and no one quite knows what value is. So, how do I shrink it down? I always ask myself, what is the biggest opportunity out there? If we're going to improve, and you made this point at the start, how do we keep people healthy? Because that's the best way to lower medical costs while raising quality. And so I look for a statistic that I can sort of get behind. What's the one that I often use these days? Chronic disease. If you look at what's happened over the past 30 years, we've seen an epidemic of chronic disease. Obesity has more than doubled from 20% to 44% in 30 years. Genetics hasn't evolved, disease hasn't happened. This is a question of chronic disease coming out of obesity. And we know that now a third of people have diabetes or prediabetes, and this is a leading cause of complications. But I look at the data from the CDC. What did the CDC find? If we could effectively control chronic disease, and they didn't mean perfectly control chronic disease, they were looking at organizations like the one that I led, where rather than hypertension being controlled 60% of the time, and by the way, hypertension accounts for 40% of strokes. Rather than that being controlled 60%, the time was 55% of the nation, we were 90%. Or colon cancer. It's a very preventable disease. We should probably have half the mortality at most because we have the screening tools to accomplish that. The nation was, again, 60%. We were over 90%. But what did they find? They said if you could effectively control chronic disease, 30 to 50% of heart attacks, strokes, cancer, and kidney failure would be gone. Now, I want you to think about that number. What would happen to healthcare costs in the United States if 30 to 50% of heart attacks, strokes, cancers, kidney failures, by the way, also 80% of lower limb amputation, disappeared? Just think about the health that would be created. There's a lot of data that says if we could manage and eliminate chronic disease, we'd extend life expectancy by 7 years, six of which would be really good, healthy years. So now we have the destination. Now we actually have the opportunity identified. It's not just pay for value. We don't know what value is, but I know what chronic disease is. I can diagnose it by a blood test. I can diagnose it by a history. I can actually find it. And now we have to ask ourselves, okay, how do you not just eliminate it? That's great. And I would definitely eliminate it if I could. The data says we have a lot of trouble eliminating it, despite everything we know about diet and nutrition and exercise and the other key factors that contribute. But how about if I just can control it well? How about if everyone who has a chronic disease is an effective control, or 90% of them are, and we can lower this disease frequency? So that's where I start to go. And then I ask myself the next set of questions. How can you do that? So we put in place the electronic health record. We were the first organizations in the whole nation to put it in place. And why did we do that? Because that way we would know at every visit, every patient who had a chronic disease and how well it was controlled. Now, as I say, I'm a surgeon. I don't really know how to take care of hypertension, but I can recognize hypertension and I can contact the patient's primary care physician. And then this is the collaboration, the cooperation. I don't say, this is your problem. I say, what can I do to help you take better care of this patient? I can write a prescription. I can order a test, but I need your expertise to tell me what to do. That's the kind of steps that we would accomplish. We put in place chronic disease management programs. We put in place opportunities to be able to improve the lifestyle medicine. We put coaches in place at our telephone centers. And why can we do that? And you noticed earlier, because we were essentially capitated. We received a single payment to take care of the population of patients. We didn't have an insurance company telling us what to do. We didn't have someone to call to get permission to do the right thing for the patient. No one had to ask. Simply do the right thing to keep the patient the healthiest. Avoid the medical error, avoid delaying care, and you're going to get the result. And so everyone understood that mission. They understood why, because it ties into this is the what, the how, and the why. You know, the how is we're going to do it in every visit. The why is because we are going to keep people healthy and lower medical costs by maximizing health, minimizing chronic disease, avoiding 30 to 50% of heart attacks, strokes, and cancers. That's straightforward, clear, and everyone understands what to do every single day. Tell them pay for value. I don't know what to do. Tell them the patient doesn't leave your office unless they've had all the preventive screening, unless all of their chronic diseases have been addressed and looked at. And I don't care whether you're an ophthalmologist or whether you're a orthopedic surgeon. Everyone is going to do that. And that is how leadership leads to actually getting positive clinical outcomes.
Dr. Pearl, I want to press you on this a little bit, if you don't mind, because I spent 5 years working at Optum, where we built out the first full risk network in New Jersey. Like you probably know this, most people don't know. On the West Coast in the United States, capitation and risk models are much more common than they are where I reside. Okay. And it's fascinating. When I used to work there and I would travel across the country, I'd be in Vegas, I'd be in Texas. It was in many places kind of normal, and they've been doing it for decades. And out here, it's still foreign concept, right? 99% of doctors out here in New York, New Jersey are fee for service. And so there's a bit of a distance there. But I want to press you on this, if I may. Before we do this, I just want to make sure for some of the less informed viewers, they understand so that they can keep up with the line of questioning. Most of the people listening to this on the East Coast that tune into us in the New York market, when you come see a guy like me, I get paid by Cigna or Aetna or Blue Cross or United each time I see you. And you get paid for a procedure or for a test you do. And that's fee for service. So the more the doctor does, the more they get paid, right? And you can obviously see why there's a conflict of interest there, right? The incentive of the doctor may be to do rather than to prevent disease. Um, Whereas capitation, what Dr. Pearl's alluding to is the payer, and I'm simplifying a little bit, will say, listen, the average cost last year of taking care of an American was $10,000. We're going to give you $10,000 per patient you take care of, like out the gate, right? Sometimes it's paid monthly, whatever, $10,000. And because you do all the stuff Dr. Pearl says, now the patient doesn't end up in the ICU really sick or doesn't end up in the ER because you're preventing them. So whatever is left of that 10,000, if you do a good job managing them, is the profit, for lack of a better term, or invested back into the system. And so you're not only not incentivized to do stuff, in some ways you're de-incentivized. You're going to keep costs down instead of be a part of the reason they're driven up. And so that's kind of the goalpost in this conversation. I want to press you a little bit, Dr. Pearl. One, there's um, is it capitation or risk, right? Because capitation itself, and it's been tried, in certain markets where it hasn't done well, because then some doctors may say, "Look, I'm just going to do less," right? Whereas if there's risk, they have to balance doing less against outcomes, meaning their pocketbook is itself at risk. Do you think capitation's enough? That's better than fee for service, or should it be full risk? And before you respond to that one, I want to give you another one that's related to this topic. Um, why is this not happening? This has been something that folks like you have done for 2 decades. Why, even though we know it's the best way to practice medicine, why has it not caught fire? What is it? The insurance companies? One would say, well, the insurance companies would want this. It makes sense from their side too. Is it the doctors? Why has it not spread? Why is it still so contained in these areas where it's been for 20 years?
Well, the reason it hasn't spread, I think, is that it's just hard to do. I mean, I was very fortunate that 70 years ago in the deserts of the Mojave Desert, Dr. Sidney Garfield started Kaiser Permanente and created this mindset, this system of care, and built it into the cultures where I wrote my second book. So that's the opportunity that I had. You've got to bring doctors together. They've got to be able to work collaboratively. They've got to be able to all understand they have the same goal, keeping people healthy. It's not battling for um, dominance, for positions in the hierarchy. They have to have a leadership structure. We had a leadership training program. We trained 2,000 of our 12,000 physicians in leadership. And I'm talking about a 2-year program with major offsites involving the Stanford Business School faculty. So it's that kind of commitment that it has to exist. Why has it often failed? Because it actually is not capitated at the delivery system level, because there's no one to capitate. You can't capitate a single physician. They control such a small piece of the healthcare pie. They can't take the risk. So to answer your question, in capitation, there is risk because basically you have the dollars that you receive. And if you can provide excellent care, you keep some of the profit, and if you provide poor care and patients cost more, you get less or negative, if you want to think about it that way. And of course, you have to have certain reinsurance and other pieces there because you could have a transplant or you could have a COVID pandemic. So, it's a complicated system, but you got to create the organization. And putting that together is almost impossible. So, although we call it capitation, 95% of what in quotes is capitation today isn't capitation. It's capitated at the insurance level, but the doctors are still paid fee for service and the hospitals are still paid fee for service. So the insurance companies have their choice. They put in place prior authorizations and claims denials. So you get into this vicious cycle. Now, is there a risk, a criticism? The answer is yes. The risk is that theoretically, in 1 year, you could make more money by skipping on care. Just don't do all these things. And as long as the patient doesn't die or sue you, you can somehow think you're getting better. In Kaiser Permanente, the average membership was 17 years. You can't do it. You've got to think about how do you invest now to reduce costs next year and the year after. You gave the example at the beginning. You see a patient twice, you get paid twice. If you could do it in one visit, why get paid? Why spend twice as much money, take twice as much time? Because of the fee for service system, it doesn't really matter what you do. You do an intervention and nothing good happens, you still get paid. In fact, if you have a complication, you often get paid twice. It's just an absurd approach to how care needs to be delivered. So I think that's why the system should work. Why doesn't it work often? Because it's hard to do, and it's just easier to focus on how do you gain monopolistic control. It's a great study from a colleague of mine, Zach Cooper at Yale, who looked at hospitals, and he found that actually now 70% of hospitals have consolidated the marketplace. They bought up all the competition, and if an insurer wants to sell a policy in a given area, they have to contract whatever the price is. If you're in Boston, you've got to contract with the Massachusetts General Hospital. You have no choice. It can charge whatever it wants. And it's figured out that it does a lot better if it can charge more than if it is able to provide care that keeps people healthier and avoids hospitalization. And I only name it because it's your brand name. They're no different than every other hospital in the United States today. So you have these battles of monopolies. The insurance companies, only five big ones. Battle of the hospitals, consolidated marketplaces that exist. Battles of consolidation of specialties in a lot of communities. And we have a dysfunctional system that drives up the prices and benefits as volume goes up and prices go up instead of benefiting when patients are healthier and the need for care drops.
And so that descriptive you provided, which is accurate, that you have, and dysfunctional is the a very polite way to put it. It's a completely upside down system. And even though the incentives used to be misaligned, fee for service and everything we've discussed up to this point, the only thing that could have made them more perverse is this consolidation in the marketplace, right? So even when these misaligned incentives existed, maybe when I was in residency, there was no health systems. It was, X community hospital, Y community hospital, Z academic center, right? And then in the course of my career, the community hospitals became medical centers, the medical centers became academic centers, and the academic centers acquired all of them and became health systems. And now almost any hospital you drive by, 70% to your point, are part of a larger health system. And of course, the rationale at that time was scales of economies of scale. Oh, and also apply economies of scale to clinical excellence. Because this community hospital, I'm a pediatrician by background, they'd say this community hospital doesn't have pediatric, whatever surgery. So if a kid comes in and needs surgery, well, now they're aligned with the health system. We can, of course, then support that. And of course, these things didn't occur. What happened is the consolidation was used not to drive down cost, but to drive up through what you mentioned, the negotiations in the marketplaces. And again, without getting too technical for the viewers, what you're mentioning earlier is the minimum network requirements insurance companies are required to have in a geography to even function, right? And so if I'm a hospital system and I have half of the hospitals in 3 counties, de facto, Cigna or Aetna has to sign on the dotted line with me or they can't play ball in those markets. And so it went from bad to worse. And the question I have for you, Dr. Pearl, and again, I got to tell you, this kind of conversation and the questions I'm offering up, I really can't offer to most. They just don't have the breadth, experience, depth of knowledge to answer it. And so I'm very happy I can ask someone of your stature these questions. When you look at that descriptive, it's complicated, it's conflated, it's upside down, it's inside out. I think when you look outside, you say a big reason, not the main reason, a big reason for this is the fundamental fact that our healthcare system is half private market and half socialized with government as the major payer and so on. And while there might be rational reasons why that was the case to begin with, right? It always starts in a rational way. The fact that you have non-market forces in the form of government and so on, but you have some market forces has made this problem very hard to untangle. So that's why, antitrust things kind of fall flat and so on. Can you talk a little bit about what your view is on that specific point? Should we be leaning more government involvement? Should we peel away and be much more private sector ethos?
Well, this doesn't surprise you. My answer is it's not going to matter. It's not working either way. I'll explain why in a second. But I was a CEO not just in the West Coast, but the East Coast in Virginia and Maryland and D.C. So I know the system there, and I talk about the fact that the East Coast is really a hospital or insurance company system. The West Coast, you say, is a medical group, but it doesn't really matter where you go. In the area I'll call it Silicon Valley. This is San Jose to San Francisco. Is 50 miles. There are 13, and I'm not counting the Kaiser hospitals, 13 community hospitals doing heart surgery. 3 of them are doing fewer than 250 cases a year. Now, for your listeners who may not be in medicine, you have to have a heart team available 24/7 because emergencies come in. How do you provide cost-effective care when you've got to pay a team to be ready and a third of the days in the year there's zero work to do? How do you have quality when your average is one case, less than a case a day? The logical thing, again, to the business students, I would ask, okay, what would you do? Everyone else says the same thing. You don't need 12. Why don't you have 3? That's what Kaiser Permanente has, actually 2 in that 50-mile range with results that are leading because of the added volume that's provided. But whether the government paid or businesses paid, at least as it is set up today, not that they couldn't do it differently, who's going to close those hospitals? The CEO closed the cardiovascular service because the volume was too low for high quality at affordable costs. He or she would lose their job tomorrow. That's the problem. There isn't any structure or leadership. The American healthcare system, the cost, if it was the GDP of a nation, would be the 5th largest nation in the world. We're talking about US GDP is higher than every other country with the exception of the US and Germany and Japan, and I think one other country out there. That's it. What country would
China. Yeah.
run without a structure, without a leader, without having coordination of care? That, I believe, is what we would actually need to be able to achieve. Oh, China was the last one. That's what we would need to achieve the level of expertise that we required. And there's no one with that authority to do it. So to me, who pays is less of an issue than how does the control do. In fact, what I'm actually hoping is that the transformative change that's going to happen is going to come from the payers, by which I mean the self-funded businesses, the businesses that purchase insurance if they're not self-funded. And if that were really to happen, then I would say that the private sector should lead it. And on the other hand, if it's not going to happen, the only funding of a capitated system is actually through the government, Medicare Advantage. So either way, it doesn't matter. That, I think, is what needs to happen. And I just don't see it coming on the horizon. I think it's going to be an industry that is disrupted and changed, but it has to still get a little worse than it is today. But again, I'll mention the book again that I said earlier. I think that the introduction of generative AI will be a tipping point that will allow us to do things we could never do before and will allow someone to come into the industry and actually provide the kind of capitated care to pay for value that we talked about earlier that America, I believe, needs. And once someone proves it's successful, we're going to see everyone else follow along.
And Dr. Pearl, I'm going to get to the your book and your perspective on um, ChatGPT and AI and so on. And is it a weapon? Is it an asset? Is it a liability in this fight to rectify healthcare? But I have one topic, if you don't mind, before we get to that, because we are dancing a little bit around the government. I think people forget, even folks in healthcare, I'm surprised, forget that the biggest payer in healthcare is not United Health Group or Cigna or Aetna. The biggest payer by far is the government. And the government, when Medicare rates come out, on the Senate floor, doctors and, all get antsy. People again don't realize that doctors' rates have been cut year after year, and there's this. Well, what are you talking about? My premiums are going, my deductibles going up, and that gets to the bloat and where all that stuff's going. It's not going in doctors' pockets. That's the misconception that I think people have. But I think I'm very apolitical. It sounds like you as well. I just kind of, think our job as doctors and folks in healthcare has to be completely unmolested by politics. You're never going to agree with everybody's views, and that can't influence how you care for someone. And actually, you have to be disciplined and proactive in keeping that kind of extradited from your thought process. And so I think we see eye to eye there. Nonetheless, in my, career, I've never been asked as much as I have in the past few months about how what's happening in the political landscape with President Trump's coming in and then administrators and the RFKs and the Dr. Oz's and Dr. Mordecai, them coming in and what this is going to mean for the average folks' health. And I think the questions are fair. They're not just political questions. I think there's cause to think that these political changes, they're coming in with a lot of momentum and they're being very deliberate about their agendas and they want to change things. And I'll kind of maybe disarm the conversation by saying what I've said. I might not agree with all these guys' views, but I don't agree with anybody's 100%, of their views. What I do think is there has to be something of a revolution or disruption. We know that that has to happen. And the fact that for the first time we have folks that kind of want to flip the table over, I think that's a good thing. That they're just kind of looking, at, first principle thinking. Let's clear the board. Let's see, now, could there be collateral damage? Could there be dangerous decision? Sure, of course, and we have to be thoughtful about that. But that's something I'm a fan of, that they're taking this, because as we've said, it's such a crazy, complicated problem that any incremental or let's do it the way we did yesterday, but just a little bit different is going to be insufficient. It's got to be this seismic kind of tornado. But I want to put the question to you. What do you make, looking at the tea leaves of this, seismic changes in the administration and these guys coming in? Do you think, and you could be as specific or high level as you wish.
Well, let me start by going back to where you began, which is the size of the government role in healthcare. Let's start with the fact that in the United States today, take the total healthcare cost divided by the number of Americans, it's $14,000 a year. Now, if you're going to purchase insurance and you're going to pay out of pocket, if you purchase insurance and pay post tax, how much money do you have to earn in order to afford $14,000 of healthcare costs? It's a lot. You can't do it on Medicaid, which goes right now somewhere in the high 20s. You can't even do it on expanded Medicaid, which now goes into the 30s. Maybe you can do it as an individual on the exchanges at some point, but you've got to make a lot more money than the average American. So the first question we have to ask ourselves is there a right? Is it part of the Constitution? Must they, the original founding documents, life, liberty, and the pursuit of happiness, is it part of the pursuit of happiness, health? Is it a government obligation? Now, my belief is yes. We're the richest nation in the world. And the fact that we're one of the only few that has right now 30 million uninsured, and before the ACA, 60 million, to me is a travesty. But others may disagree. These are values that you've got to work through. But I feel pretty strongly that if we're going to have a healthy country, we've got to have health. The second thing that I'd point out is how many people are covered under these programs. I've asked the average person, remember, Medicaid is for people who have low income. How many Americans are on it? The answer is about 90,000. Wow, 90,000 Americans are earning.
90
I'm
million.
sorry.
Yeah.
Thank you so much. 90 million Americans are earning so little that they have to qualify for Medicaid. And then you have the exchanges where people with a little bit more money get subsidized. What's interesting, most people not realize is that most people on Medicaid are working. They're just working for an employer who doesn't provide health coverage. So they work at the job and they get that coverage through the government. It's not that they're not working. In fact, a lot of other people aren't working at a job because they're taking care of someone who can't work at the job. That's the job that they have. And you have some people who are disabled and not able to work. We actually have a very vibrant Medicaid population, and even more vibrant population of people in the exchanges, and that's another 24,000. So we're talking about 115,000, more than a third of the nation is being insured through the federal government. Now we have the question of what is the new administration going to do? And no one really knows. But if you want to believe the work that the Doge Group under Elon Musk has talked about, they've said they want to cut something like $1.8 trillion out of medicine. But the president has said that Medicare, which is the largest piece of the government expenditures in healthcare, can't be touched. Social Security, which is another piece of the budget, can't be touched. Defense, another piece of the budget, can't be touched. You're looking at healthcare, this $1.8 trillion, as a centerpiece of where the cuts are going to be. Now, will they really happen? I can't tell you that. But what I can say is that if they do happen, the reason the costs will go down is not going to be added efficiency. It's not going to be waste. It's not going to be fraud. Those pieces will be tiny. The biggest piece is that somewhere between 10 and 20 million Americans will no longer have access to health care. And that to me is a major, major problem. And it's not a problem of execution, it's a problem of mathematics. Because I don't see any other way this level of cuts can be accomplished. Now, we could have a long political discussion about why make the cuts, what's happening with the national debt, what's happening with a tax cut plan, a lot of other issues. But I focus in on healthcare, which is if the government truly is able to fulfill the promise that it's made, Americans need to understand that between 10 and 20 million Americans who today get health coverage through the government are going to lose it because I don't see any other way that costs can be reduced at the magnitude that people are talking about.
Dr. Pearl, I want to get to your most recent book now. And I think it ties right from the end of the previous topic in the following sense. Anybody listening would say these two guys who, are deep in healthcare and in your case have solved a lot of problems, complicated problems in healthcare. To hear them, they seem like nice, optimistic guys generally, but gosh, this is a pessimistic conversation about the state of affairs. And I think that is why thinking something as moonshotty as AI is something that can be really welcomed because we know how difficult of a problem is. We know how just completely disruptive a solution has to be, that it can't be an incremental solution. And so your most recent book goes in on this. It goes in on, and there's no shortage of voices on either side saying, hey, AI is going to make doctors obsolete. AI is actually going to make healthcare worse. It's going to dehumanize, blah, blah, blah. There's a lot of opinions, smart people who can differ on this. But can you talk a little bit about the journey in this book? And by journey, Dr. Pearl, I mean, what inspired you to make this third book? And how you went about research or analyzing what you would put in there, and then the book and the POV you share in it.
Sure. Well, let's go back to what you said about my earlier books. My first book, Mistreated, was really about the systemic problems in healthcare. It's really a 19th century cottage industry. It's fragmented. Doctors and hospitals scattered across the community, not communicating with each other. It's paid, as we said, on a fee-for-service basis. It's basically a pay-for-volume kind of approach. The technology that we use, we think of it as being so advanced, it's really not. What people don't know is that the most common way that doctors communicate is the fax machine. When I tell my business school students about the fax machine, they say to me, "What's a fax machine?" They've never seen one. It's an 1834 invention. And there's no leadership structure. And I talked about that. In fact, I often use the words We must do this. And I'm often a little bit naive. I'm always surprised in retrospect because what I've come to realize is that because we should do something or must do something doesn't mean we're going to do it. So I looked at this question: why is change so difficult in medicine? So much more so than any other industry. I'll say maybe with the exception of religion and education, but put that on the side. Why is it so hard to change to happen? And that's why I wrote the second book, Uncaring, about the culture of medicine, the way that it kills both doctors and patients every year. And I think you're absolutely right. There was not a pessimism in it because I believe very much in the motivation of clinicians, but there wasn't a solution for how to move forward. And then all of a sudden, 2 years ago, OpenAI releases ChatGPT, and I can see that this technology is the part that's going to allow us to move into a capitated, into a value-based system. It's early, but I can absolutely see it coming. And I should say, I've never been a big proponent of AI. And I differentiate AI, the traditional AI, the Watsons of the world, or the 1,000 AI tools that have been approved by the FDA from generative AI. They're completely trained differently. The old tools are trained by taking data sets. You want to do mammograms, you take 5,000 mammograms that show cancer, 5,000 that are normal. You use deep learning neural networks to be able to compare the two. And it finds a whole series of ways that the two sets of mammograms differ. And it can actually do a good job. But it's very narrow. It's related to just mammograms. Can't do chest x rays or brain scans. Generative AI is different. Trained on the totality of medical information, trained on the totality actually of all information, it actually can provide expertise. I tell people about a podcast I was on, maybe now 7 months ago. At the end of the show, we were talking offline, me and the podcast host, and she said to me, my husband fell skiing 3 months ago. He had his arm over his head. He slid down about 100 feet. I said, you're a big skier. You're a doctor. What do you think's going on? And I said to her, because remember, this was 7 months ago, it was not quite as ubiquitous in terms of generative AI. I said, you said to me on the show today you've never used ChatGPT. Go use the free version. Put the symptoms in place and see what the application says. 5 days later, she calls me. She says, thank you so much. It said that he probably tore his rotator cuff, that he should have an MRI to confirm the tear, and he should see an orthopedic surgeon because he almost definitely needed to have a surgical procedure done. And she said, I went to the surgeon. He said, you probably have a torn rotator cuff. He ordered the MRI. He did the surgery. He said, if he'd waited 3 more months, I probably could not have reattached the torn tendon because the muscle would have contracted. That is expertise. And it's expertise at the patient level. I mean, you're a physician. Tell me one technology introduced across all of history that was designed for the patient, not for the doctor, for the patient. One technology that would empower the patients. Why I call the book ChatGPT MD, How AI Empowered Patients and Doctors Can Take Back Control of American Medicine. So I said, finally, we have this tool that can now translate it into action. And why do I say that? Remember, early on today, we were talking about chronic disease. Now, when I was the CEO in Kaiser Permanente, we did a great job managing chronic disease, but it was very expensive. Why did we do it? Because we were capitated. Why did we do it? It was in our culture. But the point being is that it was expensive. We used hundreds of nurses to accomplish it. This technology can now do the same thing. Across the campus from the business school at Stanford is the engineering school. They have Band-Aid sized monitors that can read blood pressure, pulse, blood oxygen, blood glucose, you name it. Highly reliable, 99.9% reliable, accurate. And yet I can't find a single doctor in the United States today who's using these for their patients. Now, why not? Take a patient with hypertension. They come to your office, you diagnose hypertension, you start them on a medication. You say, "I'll see you back in 4 months." 4 months later, they come in, the blood pressure is still elevated. You got white coat syndrome. "I'll see you in 4 more months." It could be a year before that blood pressure starts to be controlled. Put on wearable monitoring. Take 3 readings a day. At the end of the month, you know there's 92 that are normal and 8 that are abnormal. How's the patient doing? No one knows, again. And I don't know a single physician who wants to get 100 blood pressure readings for all the patients with hypertension. And generative AI tool has no problem taking those, looking at the first and second derivatives, figuring out how you're doing it. 1 month, if you're doing worse or not any better, change the medication, change the dose. This is the kind of intervention we can do. As doctors, we get a hemoglobin A1C every 3 months. Why is that? Because we don't want to see the patient for 3 or 4 months. We could measure blood glucose, do the same thing all the time. We could have a technology that can see patients with heart failure, figure out when they're going into pulmonary edema, figure out when they have heart failure by a progressive swelling of the legs and inability to climb stairs. We can intervene days in advance. But we don't do that. The opportunities with this technology, to me, are so exciting. And again, I'll go back to that same statistic. Imagine if we could use it to lower heart attack, strokes, cancer, and kidney failure 30 to 50%. What would the American healthcare system look like? And I'll tell you, we wouldn't be spending 18% of GDP. We'd be where every other nation is, 12 to 14%, where every other very wealthy nation is. To me, we finally have this outcome. Now, how did I do it? I actually wrote it with ChatGPT, and I did it for 2 reasons. By the way, when I say with ChatGPT, what I mean is the same way I would write a paper with a resident or with a medical student. Send drafts back and forth, do research around it. I did it to get more experience. This was a new technology. I wanted to see how well it worked. But I also knew that if I couldn't publish this book in 6 months, my first 2 books take 2 years from start to finish in publication. I only had 6 months because by the time a year passed, it would be outdated. And I don't want to say it's outdated now. I think it's still the leading book on the subject. But DeepSeek just released an OpenAI source created for a much lower amount of dollars using distillation. Is going to have even a more massive impact on healthcare, as now dozens and hundreds of companies, entrepreneurial, innovative companies, can create products that distill off of the current tools, by which I mean they don't have to recreate for hundreds of millions of dollars the entire large language model. They can use the ones that exist, pull out the information they need, and then train it with information based upon actual human experience in healthcare. The opportunities, I could not be more optimistic than I am at this moment.
Well, I think if that's not a call to action to read this new book, nothing is, and that's kind of the silver lining, I think. And I want to thank you, Dr. Pearl. I have one question before we just close out. Um, I don't think I know anybody who the answer to this question I would kind of respect or take seriously than you. So I'm just going to exploit this opportunity on a selfish basis. 2030, on the other side of this administration, not on the other side, but let's say definitely in the third or fourth inning of the chat GBTs and the AIs, right? And so on. 2030, how does our healthcare system look relative today? Is it cheaper and better? Is it more expensive and better? Is it more expensive and worse, which is how it's been going? How does our healthcare system look in the next half to full decade with all these massive political changes, massive technological changes?
What did Yogi Berra say? That the future is always hard to predict, especially when it hasn't yet come? That's the challenge. So if you tell me that someone, and that someone could be a self-funded employer, it could be an insurance company, it could be doctors, it could be the federal government. If you tell me that someone is going to actually have the vision and be able to transform American healthcare, I'm going to tell you it's going to look amazing. That we will have elevated the health and elevated the medical care to all Americans, particularly those at the bottom of the socioeconomic scale, particularly those in rural areas, particularly those who today can't access the excellent medical care that some of us take for granted. I will tell you that under this scenario that we will have chronic disease controlled 90% of the time, that people will just routinely wear these Band-Aid sized monitors, they'll have readings every day. I think we'll actually have a commitment to being able to do the things that we can to prevent chronic disease and to better manage it. We're going to eat healthier and exercise. I think we'll have a much healthier and I think actually maybe a more collaborative, cooperative society than today. And we will see that as being the next renaissance of American and maybe global medicine. And on the other hand, I can say that if people are in power today say that they're not willing to make the changes, if insurers continue with prior authorization, if hospitals continue to consolidate, if doctors continue to sign up with private equity, we can go down the whole list of things of ways people have tried not to change. If that's the case, we actually will be a lot worse with more people uninsured, with a less healthy country, with medical costs being ever higher, and only a few people, not very many, will be using the technology in the way that it could be. This is truly a fork in the road. Up to now, there hasn't been a fork because there was no other alternative than the systems, the technology, and the culture that existed. We now have that opportunity, and I'm hoping that you or our listeners or anyone else will have the courage to step forward, have the willingness to take the chance, and have the commitment and values to make our country once again a healthy nation and the leader in the world's medical systems.
Uh, Dr. Pearl, you've been very kind to take an hour out of your time and share your experience and your wisdom and your perspective with our audience, and with me. I want to thank you for making the time to do this. I can only hope that when you do make it out to the New York market, that I can have you over. Maybe we could do this live. We could have a cup of coffee and go for a couple of hours. I'll buy you dinner or something because this has been a ton of fun. A ton. The mental exercise that I've enjoyed listening to you is what I live for. And one of the things the other day an Instagram live, like once a week, and people actually ask questions live. And one of the questions was around, hey, Dr. Baker, who controls the healthcare system? Is it the doctors, the insurance companies? Is it whatever, the hospitals? I know, and my answer to them was that, in my mind, it's the health insurance companies. My heart is actually the patients, that you have to control your own healthcare outcomes, right? Because there's all these pieces on the chessboard. There's good doctors and maybe, other doctors. There's hospitals that take quality seriously. Whatever. But you have to be the driver of your healthcare as a patient. You shouldn't defer it to the doctor. You shouldn't defer it to the hospital. You shouldn't just leave it up to them. As much as we like to think as doctors that, we're doing God's work and we're helping, which we are, we still, every patient dies and there's always bad outcome, and we still haven't cracked the code, and we need a patient who's engaged to be the driver, and we need to be co-pilots together. And I believe that. I do believe that the most important person in the healthcare system to any individual is themselves. I think guys like me and you can help them out a lot, but I think they have to be the ones who kind of, it starts and ends with them. And to that point, I think, while this is probably an incredibly valuable conversation to young doctors, to healthcare executives, I think it's critically important to just the average patient to hopefully absorb a lot of what was said today, see kind of the glimmers of hope, and understand how to be empowered for your healthcare. And I could not, I can't thank you enough for spending this time and being so insightful. And you really are just you have a gift to be able to bring, it's one thing to have accomplished as much as you have and been as successful as you have in a very challenging space. It's a whole nother thing to be able to translate that in an articulate, effective, and inspiring way. And so again, I want to thank you very much, and I hope to do this again.